I'm Diana Marrero, Director at The Hill. Welcome to this morning's briefing. Mergers and Innovation, Measuring Performance in Patient Care. I'd like to start out this morning by thanking our sponsor, 3M, for making today's program possible. The American healthcare industry is undergoing rapid change. From mergers and acquisitions to the creation of new entities to tackle rising healthcare costs, these developments are poised to significantly influence the delivery of patient care. And there are opportunities to use mergers and acquisitions to improve the quality, accuracy, and efficiency of patient care? How can we measure the performance of healthcare innovation? And what is the role of Congress in ensuring that the consumer remains at the center of all these changes? This morning, we'll be hearing from leaders in government, Congress, patient advocates, and health economists. Before we begin, a few housekeeping notes. Please keep your phones on silent, but we do encourage you to engage in the discussion on social media. We will be recording the on-stage conversations. The video will be available for viewing after the program on thehill.com/events. You can follow us on Twitter at @TheHillEvents and comment using the hashtag #TheHillTalksHealthcare. We're going to be taking questions from the audience during this program, so please be on the lookout for members of our team with handheld mics. And finally, there's a short feedback survey on our chairs. We'd love to hear from you about our events, so please take a moment to fill out the surveys at the end of today's program. Let's dive right in. We begin with Senator Bill Cassidy. Senator Cassidy is a physician and member of the Senate Help Committee. A leader on healthcare issues, he recently put forward a white paper outlining ways in which the healthcare system can be made more affordable while improving patient outcomes. Please join me in giving a warm welcome to the senator. And joining him on stage is my colleague, Alexis Simendinger, the Hill's national political correspondent. Alexis, over to you.
How are you? Senator, it's great to see you. Thank you so much for joining us.
Thank you for having me.
Taking a break from the calmness, the comedy of the Senate. We're here to talk about, hopefully that feedback will leave us. We're here to talk about this interesting, fascinating trend, as you know, the mergers and acquisitions in healthcare. And we're going to leave plenty of time for questions for all of you who have detailed questions that you'd like to ask the senator. We're going to have time at the end. We're going to ask you to stand up and introduce yourself. And then later on, of course, we have a panel with my great colleague, Peter Sullivan. So let me start off by asking you, as somebody in government and somebody who has been in healthcare as a physician, as someone who started off with a career with nonprofit clinics in Louisiana and has seen it all, do you think the innovations that we're watching in the health industry right now are more likely to be driven by the private sector, what we want to see in healthcare for patients and for affordability, or by government?
That is a complex question. Because what we see right now in the private sector, first let's start off. What you have to have foremost is the patient, sitting around her kitchen table, unable to afford her bills. And since 2007, what she spends on health care has increased by 25%, and what she spends on everything else has decreased. So increasingly, health care is consuming her budget. If you look at some of what's happening in the private sector, it is awful for her. The consolidations of providers, where studies show that when hospitals combine, cost increased by 12%. The consolidation of insurers, where if you have only one insurer in a market, that's basically monopoly pricing, and they can raise their rates to whatever they are, and on the individual exchange, the federal subsidy just follows whatever they decide to bill, because it is a monopoly. For her sitting at her kitchen table, we actually need we need more competition. So if the private sector consolidates, that's bad. If the private sector, with directive from the government, puts in something such as price transparency, we have that in our white paper, price transparency, that's good. It allows her to get the benefit of competition where she can use her health savings account and get the better price. So there's no simple answer to what you just said. It could be awful if it's consolidation. It could be fantastic if the federal government or the state governments drive price, something such as price transparency, which gives her more power as opposed to just being subject to the consolidators.
Let me ask you for your analysis. What do you think? This trend is not new, but it certainly is accelerating, and it's expected to continue in 2018. What prompted this trend? Is it a search for profits and competition?
The consolidation?
Yes.
Consolidation has begun at least 20 years ago. But if you will, it's mutually assured competitiveness. So as insurance companies consolidate, they have strength relative to hospitals. So hospitals consolidate, so therefore that returns the strength. And physicians attempt to consolidate, never quite as successfully, more often bought either by insurers or by hospitals. But nonetheless, they're all attempting to improve their negotiating position one with the other. Now, going back to that woman sitting at the kitchen table, surrounded by hungry children trying to make ends meet, they are making more and more money, and she is paying more and more. She is the least able to pay more and more, but she is the one who's being called to either by higher taxes or higher premiums or lower take-home pay as her employer pays more. We've got to lower the health care costs for her. Competition improves it. And again, I'll discuss that more fully in my white paper.
You're describing a sort of on the one hand, on the other hand kind of equation, the way you look at it right now. As this experimentation and this collaboration continues, how are you going to assess the value for patient needs, for transparency, which you just talked about, for affordability? How does the Senate and the Congress grapple with that question?
Hopefully we grapple. I will say that to an extent it has been lost. But you can look, since 2007, the amount the average family has put towards health care costs is well documented. It is increasing. If you look at the premiums, they've increased, both in the individual, particularly in the individual, but also in the employer. But the deductible and co-pays have increased even more dramatically. So one, it's clearly documented. How do you judge success? You judge success by whether or not we begin to implement those things which give the patient the power. Again, I can be exhaustive, but we have it on our white paper on our website. But if you give the patient the power, you lower cost. For example, one thing the administration is seeking to do is to eliminate so-called gag clauses, where a pharmacy benefit manager will tell a pharmacy that you, by contract, cannot tell the patient if she would save money by paying cash, because paying cash is less than her deductible. The pharmacist is not allowed to tell the patient because of a gag clause. That is wrong. And that makes her pay more, so someone making much makes far more. I can give you other examples, but if we have price transparency so the mama can scan the barcode, if I get the CT scan for my daughter right now, it costs $2,500, but if I go Thursday at midnight, it costs $250. Baby, we're staying up Thursday. Now, she then has the power in her HSA to get the better price for her family. She needs that power. Now she does not have it.
Do you think, though, that consumer choice or consumer knowledge is enough? Is that, or is there a larger role for Congress? You started by saying hopefully that Congress will grapple.
So Congress can set up rules, but it cannot micromanage. Mm-hmm. It is terrible when it micromanages. But if it sets up rules of the road, for example, you have to provide, if a patient is paying cash, a provider must provide what the all-in cash price is for elective procedures. Think CT scans, blood tests, et cetera.
So you're supportive of that?
Totally. And that a pharmacist must publish what the cost of a medication would be so that the patient can know that price before she walks in the door. Another example. Consumer Reports had secret shoppers go out and look for 5 different generic medicines. And the price ranged from $44 to $700 for the same generic medicine. The patient wouldn't know that it was $44 here and $700 there unless they happen to knock on every door. If we give her the power of knowing the price before she walks in, and Congress can set up that rule, then the market will respond and she will pay less. That is a good thing. She must have the power, and if she has the power, then prices will come down, and we must control healthcare costs.
Before we leave this, because you're a physician and you started off working with a lot of low-income patients, dental patients, healthcare patients in Louisiana, is it your experience that all consumers have the capability of doing this, being smart consumers?
So what you're suggesting is that sometimes the healthcare system is too sophisticated for someone to gather. So you couple that with the patient-physician relationship. Statistically, if the patient has a strong relationship with the provider, then, and if they both have kind of alignment of the patient's physical and financial health, that is optimal. The patient cannot know who is the best gastroenterologist for her particular condition, but the doctor knows. And if they have a mutual interest in making sure that her physical and financial health are respected, and there's systems of care that do that, then together they augment her power, and so that whatever sophistication, knowledge base she lacks is compensated by the physicians. Again, there are systems of care that do that, and well worked out statistically and academically analyzed, and that's where we need to be going.
Let me take you to your proposal, which has stalled. This is an election year, but your proposal to try to tackle the healthcare challenges and find consensus. You were talking and proposing block granting federal dollars to the states.
No, per capita cap, which is somewhat of a different concept, but I'll cut you slack.
Okay. Would your proposal be supportive and actually complement the trend that we're seeing in mergers and acquisitions in the private sector?
So, if you're talking about mergers and acquisitions on the insured, then clearly they will respond to however the payor decides to pay. And if you make it where, as the Federal Employees Health Benefit Program, Alexis, I suspect your own employer says to the insured, to the insurer, we have this many employees, they are this age, this gender, they are of this health status, based upon experience, we're going to pay you a certain amount of money per enrollee, adjusted for all those factors. That's what they do. By the way, our per capita cap did the same thing. Our per capita cap, the federal government would do to the state what states are doing with Medicaid managed care, which is that we have this many patients, this gender, this race, this whatever, and we're going to give you a risk-adjusted amount per patient. That is good. The reason why? Not only does it help control cost, but it decreases unnecessary utilization. If you pay people no matter what volume and intensity of service they provide, you spend a lot of money, but there's also going to be more complications. Once you actually have somewhat of, okay, it has to be justifiable, then not only do you conserve cost, but you also have an appropriate volume, an appropriate intensity, and the patient is better cared for. So our per cap, mergers and acquisitions, they would respond to that because they responded to it on the state level. They have responded to it in the large group health level.
Okay, let's open it up to questions. There's microphones here. If anybody has some questions, please raise your hand and the microphone will find you. Please tell us who you are and who you're with, and Senator Cassidy will respond.
Hi, my name is Nam Nguyen. I'm a cancer physician. I just want to ask you why the cost of the medication is so expensive in the US compared to Canada, for example. And it affects us directly. I have a patient, like you mentioned, who got cancer. She got radiated mucositis. I prescribed her a medication for mucositis. And the next day she came back, she said to me, "Doctor, I'm retired. That medication costs $500. So I have the choice either not eating, take the medication, okay, or take the medication and cannot buy medication. And there's no generic for that medication."
Yeah, so the question about high drug costs in general, I think will cover your question in particular. Again, our white paper has on our website, has a fair amount of sections on high drug cost. There is no single thing which is driving up healthcare cost. But on the other hand, there's lots of things on the margin that are acting towards it. So if you want to look how new drugs are marketed, there was a series of articles in the Wall Street Journal that looked how Pfizer was marketing a new cancer drug, and it's basically what the market would bear. They did market research, what would an oncologist prescribe, and when they did that, then they would then peg their price there. And it turned out to be quite expensive. So we have kind of an upside, but no restraint upon what the initial drug cost would be. If you're talking about the pharmacy benefit managers, which are asking for very high rates from the pharmaceutical manufacturer, they rebate a large amount of that back to the insurer, but in most cases right now, patients are not receiving so-called point-of-sale rebate. They're paying the gross price, not the net price. The patient in her copay, in her deductible, is not getting the advantages of the negotiated net price. So that's another reason. We could go on, but in the situation you described, both of those could be the case. And again, in our white paper, we have different solutions as how to address that. And I won't give a litany here, but please go there and look at it, and we'd love your feedback.
This gentleman right here on the aisle.
Hi, my name is Shivam Shah. I'm a medical student. Thank you very much for being here. My question was, do you think that the United States should use, on a broader level, should use yardstick competition to a greater degree?
Should use what?
Yardstick competition when trying to identify pharmaceutical prices, kind of looking abroad and seeing what other bins of countries are doing. And then maybe on a more system-wide level, use more tiered formularies for drug price, to mitigate high costs for drug patients to patients.
So we in our white paper do reference pricing, where the U.S. would look at what maybe 5 or 6 other large developed economies are spending on certain drugs. Germany, France, Great Britain, Canada, and Italy. Pick a number. Japan, Australia. And you put reference pricing. Now, there's a couple reasons for that. Pharmaceutical manufacturers will say, wait a second, we rely upon the U.S. market to get all of our profit, otherwise we cannot. Well, frankly, if you start linking ours to what they pay, maybe they would have more of an incentive to get more money from those foreign markets. Now, by the way, it doesn't have to be 1 for 1. It could be a multiple. It could be 1.6 or 1.5 or 1.1. But that would be a way to have some sort of connection with reality. You mentioned the reference pricing. Yes, we do think that would be something to be considered. And there was a second part to your question?
The tiered formulary?
Tiered formulary. Yeah, tiered formulary, going back to aligning the incentive between the patient and the doctor, it may be the doctor knows that if I give an infusion which costs more, I'm going to have fewer complications, and the patient's more likely to be compliant and less likely to come into the hospital. So that's why I'm so much into this patient-physician relationship, because sometimes a tiered formulary is great in concept, but then the patient's non-compliant and you end up with cost on the back end. Whereas if the doctor says, wait a second, we have an aligned financial incentive, I don't want to spend money because she's out and I'm out both, I want a better outcome, and global life cycle costs will be less if I give a more expensive medicine, that's when you bring the expertise to bear on this particular patient. So I'm very much kind of sure in concept you can do tiered formulary, but I much prefer that sort of thing which I just described.
Senator, we promise to let you go. Thank you so much for being with us this morning, and we'll look forward to all that you're up to the rest of this summer and into the fall.
Thank you, Alexis.
Thank you very much.
Thanks.
Applause for the senator. Thank you.
Thank you, Senator Cassidy. Alexis is staying back for the next conversation. And now I'd like to invite on stage Congressman Gene Green. He's the ranking member on the House Energy and Commerce Subcommittee on Health. We're looking forward to hearing from him this morning about the role of Congress in ensuring that changes in the healthcare landscape are focused on creating value for patients. Welcome, Congressman Green.
Thank you.
Thank you very much. I don't know if you had a chance to hear some of what the senator was saying, but you certainly are familiar with the discussion. So let me start you off kind of where we left off with Senator Cassidy, and that is he has a kind of a, on the one hand, on the other hand, assessment of where mergers and acquisitions in the healthcare industry and the private sector may be leading us. So let me start there with you and ask you, are we seeing this trend because of government involvement in healthcare or in spite of it?
I think it's in spite of it. Now, the only hearing we had on the House side was Judiciary had a mergers and acquisitions in February, but our Health Subcommittee hadn't been approaching it, but we haven't had any hearings. But obviously there's some interest in it, particularly when you have Berkshire Hathaway, Amazon, and J.P. Morgan Chase that could probably form a pretty good sized insurance company, although so many of the large companies already are self-insured. They just partner with an insurance carrier to provide it. So, but it hadn't been focused on, at least in the House, except Judiciary.
Do you see that as an innovation, a real innovation, or is it a little early to know?
I think it's early, but I think the horizontal would be more of a problem, and that's what we're seeing. Although we lost a hospital in Houston because of the flooding, and they had been flooded for many years, but the mergers from hospitals and from insurance companies together is probably much more problematic than it is the lateral.
As a Democrat, when you are assessing the landscape of these mergers and acquisitions, what are the indices that you're looking for? What concerns you? You mentioned one, losing a hospital. What's your base value that you start with when you're assessing this trend?
Well, what I'd like to see if it a more expansive coverage of folks. In our country, we decided back during and after World War II we were going to have employer-based, and even with the Affordable Care Act, employer-based insurance covers more people than the ACA ever would. And to see how we can expand that to have more people covered, whether it's from Amazon, from somebody working on their warehouse floor up to the highest employees, to see that they have quality insurance for their families. And again, Berkshire Hathaway that owns tons of companies that to make sure they could expand the coverage for health care instead of restrict it.
So you were talking about, are more people covered? Are more people getting health care? How do you fit into the idea that some assessments are that this trend that we're seeing is driven by costs and competitiveness, as opposed to the concept of, can we cover more people? Are we offering more quality care? Is all of that built in, or are you concerned that some of that will be missing?
Well, again, the private sector can do that, but I think to pass the smell test on, you need to show some things that are actually much better, other than just saving money, more efficient delivery of health care. And that's a lot of our goals, though, have more access. And if we can do it for the private sector, that's great, just so we get it done. And that's something I'd be looking at. Again, the horizontal mergers between, an insurance company and CVS or something like that may not be the problem that if we had, Cigna and another company merging together. And so that would where you'd look at some antitrust issues.
With your long experience in Congress, listening to healthcare debates over how many years? Lots.
26 years.
Yeah, 26 years, 2 decades, more than 2 decades. What's the role of Congress in watching this private sector trend, and which is going to be increasing this year? What's the role for Congress?
Well, I think on a bipartisan basis, because the senator actually served on our committee before he was elected, and coming from Louisiana, he doesn't make fun of my Texas accent, and I don't make fun of his. But I think he and I worked together when we were in the House, and some of the things he does in the Senate, I think is a problem solver, and that's what we're looking for. Whereas depends on the leadership of the House, what issues you focus on. Of course, anybody watching a health subcommittee knows the last month or 6 weeks or so, we've been immersed in opioid addiction legislation that we finally passed most of it out. I think there may be a couple of bills left last week, so that hadn't been on our radar screen.
All right. One of the things that folks are talking about is maybe the employer-based insurance healthcare coverage system is ebbing away. Do you believe that's true?
Well, I've heard that for a long time, and we did have, 25 years ago, our employer-based insurance was fine because most employers covered their employees. But about 25 years ago, employers realized, particularly smaller employers, that they didn't have to cover their employees. And so we ended up with such huge numbers of uninsured showing up in our emergency rooms without any kind of coverage at all. And that's what brought about expansion of the Affordable Care Act, we tried to build on the employer-based insurance. And like I said, today, we still have more people being covered by their employer health care than will ever be part of the ACA, and trying to add coverage to people who didn't have it through their employer. And, you know, the requirement that if you have 50 or more employees, individual mandate that, of course, this administration is not helping things. So.
Do you buy into the idea that the Affordable Care Act is partly a catalyst for this private sector trend that we're seeing?
I think you can't take anything out of it when you make a business decision, particularly on the level of a J.P. Morgan or Berkshire Hathaway. They might have not have done this if we didn't put together, have the Affordable Care Act. And the problem with the Affordable Care Act is because of the controversy over the last 8 years that you can't fix it. We've gone all these years, and if we had created Medicare in 1965 and not over the period of time since then adapted it, it would have been in trouble too. So we haven't been able to do anything except keep it on the books, but it's been chipped away at. And so we're going to see more uninsured because of the lack of the ACA. And I think these companies are looking at it because ultimately, if you're a company that has insurance for your employees, the uninsured, you're going to pay for it. Somebody's paying for it. And that's why everybody has skin in the game. Everybody ought to have some type of health instrument. And of course, in Texas, we didn't expand Medicaid. In our district, 46,000 of my constituents in Houston would have received Medicaid if the state would have taken the 90% reimbursement of it. So sometimes politics gets in the way of good policy.
Ah, shocking.
Shocking.
Shocking. Let me ask you, because of your long experience, you've watched 2 Democratic presidents, now 2 Republican presidents, many Congresses wrestle with health care. You have a daughter and a son or son-in-law who are physicians working in the business, in the industry, in healthcare. And we're listening to Democrats politically debating about where we should go forward, right, in the next iteration of this political debate. Do you have any advice for the Democrats who are seeking to win seats or maybe thinking about 2020 about where you see this debate going? They seem to be thinking it's some of them single payer or government based, not private sector as the answer. What do you think?
Well, obviously at the Democratic rallies, Medicare for all or single payer is the popular thing. But when you come into Congress, we have to find something that has 218 votes and can get through the Senate. And our problem with not being able to fix the Senate, and you may remember that Senator Kennedy passed away and the Senate lost our votes over there, so we couldn't have something that the Senate would do. So that's what, for the last eight years, all we've heard is repeal and replace. Obviously, that hadn't worked out very well either.
So your advice to Democratic candidates is what?
I think they need to be reasonable and say, sure, ultimately, and I use this argument, all our industrial competitors that are democracies, Western Europe, Korea, Japan, have some type of national health care. And we created them after World War II. And yet we still stuck with the employer-based that began in World War II and afterwards. And like I said, for decades it was fine until employers decided that wasn't their responsibility. And if we want to make employer-based insurance work, free market, then we need to make sure it's effective. And employers need to cover with a quality insurance plan. We're seeing some, what the administration's trying to do with these slim down plans, but having served before Congress 20 years in the legislature, and I watched us trying to come up with a plan in the state with that, and you end up, if you don't pay the money, you don't get the quality. It wouldn't cover maternity, it wouldn't cover emergency rooms. I had a constituent who worked for a large retail operation, and before the Affordable Care Act, and she found out she had a terrible illness, and it was going to cost $250,000. That insurance policy was only paying $20,000. So we don't want to go back to those days.
We have time for maybe one question or maybe 2. Let's see. Anybody wanted to ask the Congressman a question? Hands up. Anybody? Let's hear from this young lady here. Who are you with?
Good morning, Congressman. I'm actually with 3M. So welcome, thanks for being here.
Thank you for the use of the hall.
I'd be remiss, I know we're talking a lot about mergers and innovation, but I'm sure you're aware one of our biggest priorities in healthcare is the repealing of the medical device tax. We've heard from Leader McCarthy that they may actually bring this to a vote in July, Mr. Paulson's bill, and I'm wondering your thoughts on that. We cannot not talk about it with discussion of innovation. The medical device tax really hurts companies when they're innovating. It hurts jobs, it hurts research. 3M obviously felt those consequences when the device tax was in place. So I'd be interested to hear your thoughts on that.
Well, if you're talking about the medical device tax, that wasn't a House proposal. It was part of what the Senate sent us in the Affordable Care Act. In the House, we voted that down in our committee. And we're not to help pay for the Affordable Care Act with the device tax. We had it paid for different ways. My worry about that is I don't want to stifle innovation. I want to make sure whether it's a new formulary that can help somebody with diabetes or a cure to cancer or anything else, I don't want to put a disincentive there that we wouldn't do it. Although the incentives may be in Europe or Asia, I would rather that incentive be here in the United States with our researchers.
Great. We have time for one more? Let's see. Maybe wait for the microphone, this gentleman here.
Yes, good morning, Congressman. Dr. Richard Hartman, Chief Strategist for Air Force Surgeon General. It was interesting that you brought up the issue about Berkshire Hathaway, JP Morgan, and Amazon. That's not a merger acquisition, that's more of a collaborative.
Yeah.
But what I think this is more of a comment and something probably for you to think about when you go back to your committees, is that they're focused on the employees. So when they focus on the employees, that's not where necessarily their costs are. So if you look at their strategies and how they're developing it, what they miss is what you discussed was the beneficiaries, which I found was unique, because you're saying that, but when you look and see where they're going, where their strategies are not that. But I think there are people within government, such as the Department of Defense, that you can look at to see how we're doing things that focus on both beneficiaries as well as the high-performing, individual that we want to take care of, to enrich that, what I call consumer. They're not patients until they get sick. They're consumers, and that provide a relationship.
Okay, let's leave time for the Congressman's comment.
That's correct. I would hope that's what the collaborations, but that's available now with self-insurance, I think. They could probably, if those three entities wanted to come together, and they can literally write their own policy if they want to do. But again, it doesn't do any good for a company to cover the employee without covering the children and the family. And again, maternity, lots of things. My son, who now is managing a company, when he was 10 years old, he liked to skateboard on curbs. And so we had a broken wrist. We had all sorts of problems. But I was fortunate enough to be at a company that, at that time, because I was in the legislature, that actually had insurance for our, it was a bargaining unit, though. We had insurance through there for our beneficiaries.
Great. Thank you. We promised to let you go on time.
Okay.
And thank you very much, and enjoy the rest of the week, this tempestuous week in the House.
Yeah.
Thank you very much for
you.
joining us.
Thank you, Congressman Green. Alexis will stay back for this next conversation as well. I'd now like to introduce Deputy Secretary of the Department of Health and Human Services, Eric Hardin. One of his department's top priorities is to reform, strengthen, and modernize the nation's healthcare system. How does that goal intersect with the changes taking place across the healthcare ecosystem, and what is the role that regulators can play? Let's find out. Welcome, Deputy Secretary Hardin, and the floor is yours, Alexis.
You're pretty happy to be here talking about this topic and maybe not another one at the border, aren't you?
Yes. You bet.
Yes.
Absolutely.
Good morning.
Good morning.
We've been listening to the Senator and the Congressman talking about this trend that we're seeing in the private sector, and you're very aware of it. You were in the private sector. You have a wealth of experience in government outside of it. So let me start where I started with them. From HHS's perspective, do you think that the trends that we're seeing in terms of mergers, acquisitions, collaborations, trying to find abilities to scale up,
Sure.
are they being prompted sort of by government, or innovations that we've seen by government, or in spite of it?
Sure. I think that we're kind of looking at a mixed bag here. Sometimes we have, obviously sometimes the drive to kind of consolidate care can drive up costs in the system, and sometimes inadvertently the regulatory or the reimbursement system really supercharges that drive towards consolidation. Things that government might do, sometimes inadvertently, will lead to consolidation that may or may not drive up costs. In many cases, we want to be in a situation where we're kind of level about the issue of whether we should have consolidation or not in an industry. That's talking purely from kind of a merger and acquisition point of view. But the drive to coordinate, I think, is separate from that. The issue of whether or not who owns it is different from the question of whether or not they should be coordinated. Because coordination can have a lot of benefits for care, regardless of who is sort of owning the assets within the system and along the chain. So we want to be able to enable helpful coordination among different players in healthcare to make sure that patients get the best care, that you kind of have end-to-end treatment where you don't lose the patient somewhere in the system, and be able to enable them to get the best kind of care from all the different actors in the healthcare sort of chain, the continuum of care. But we want to make sure that nothing we're doing is inadvertently driving either harmful consolidation or disaggregation from that point of view.
Before we get to the tools that HHS is using, from your perspective, and considering the sweep of jobs and career entries that you've had in healthcare, what concerns you about this trend, if anything?
Well, I think the concern here is that we end up with a system that is not responsive enough to patient needs, that we sort of inadvertently drive ourselves to a situation where we have sort of the wrong level of coordination. There's a way in which you can sort of capture patients within a system that might not create the best model of care. And we don't want to inadvertently sort of lead ourselves into that. So I think that's one of the things that we want to enable coordination, and that's part of what I was trying to do with the regulatory sprint to coordinated care. I think that we've seen over time some of the laws that we've put in place that were attempted to kind of get at some of the problems of the prior versions of our healthcare system are now working kind of at cross purposes with where we're trying to go.
Talk a little bit more about the regulatory efforts that HHS, you're spearheading. This is an area that you're intimately familiar with from your past experience. And in the private sector. Talk about what you're trying to do in the time frame.
Sure. So this is the regulatory sprint to coordinated care, and those words are kind of chosen carefully. One is regulatory, so we're going to try to do things that we can do within HHS from a regulatory point of view. It's a sprint because the system we've got could need years of analysis before we get to understanding how to make it perfect. So we're trying to get kind of the low-hanging fruit. We're trying to do this in a sprint. That is, try to identify things that we can do quickly to enable coordinated care. And then we're focusing on 4 areas that have where we've heard a lot of feedback or experience that there have been problems in this area. The Stark Law, the Anti-Kickback Statute, HIPAA, and 42 CFR Part 2, which is a provision that a lot of people in the opioids and substance use disorder area think is harming their ability to coordinate their care. So each of those laws was set up for a good reason, and they have to stay in place in many cases. It's just that sometimes sort of well-meaning adjustments over time have resulted in kind of an incrustation of regulations and guidances over time that we now think we could kind of usefully kind of get rid of some of those or enable better coordination between the systems of laws. We got 4 different agencies that each have places. They each have different regulatory capacities in here. So whether it's CMS with Stark, whether it's the Inspector General with the Anti-Kickback Statute and the safe harbors there, whether it's SAMHSA with 42 CFR Part 2 or the Office for Civil Rights for HIPAA, you have 4 different agencies that are each kind of carrying out their own law. And of course, naturally, over time, those 4 agencies are kind of going to get out of whack with each other. They kind of get out of sync. And so we're going to try to make sure that we preserve the patient rights and the protections that are in those laws and the protections for the system overall, while enabling sort of a lowering overall of burden where it's unnecessary. We have duplication, unnecessary regulation that, you know, one of the agencies covers something, the other one does too, but a slightly different way, which leads to confusion out there in the industry. Do I follow this agency or that agency? They're both speaking to the exact same issue. Which one should I follow? Well, the agencies can decide between themselves. Maybe I should handle this one, and you handle that one. I'll handle this one, you handle that one. So that coordination is something that we can do usefully at kind of the departmental level. We can kind of sponsor that, bring them together along with listening sessions for stakeholders, whether it's patient groups, industry stakeholders, to kind of get them in a room and let us know where they see the problems as well.
Just to follow up, there is no legislative effort that you're making in those four categories, those four triage elements that you were talking about. You want to try to do this through regulatory, administrative efforts.
That's my focus. I mean, there are obviously, there have been, I mean, Congressman Stark, who started the Stark Law, has kind of criticized his own law. So his self-named law, he himself has come out to say that there are issues with it. But that level of sort of the legislative attention there may be going on otherwise, but that's not really the focus that I'm bringing to this. I mean, that's my background as kind of a regulatory and corporate lawyer. This is a place where I think I can usefully kind of bring my experience to bear most usefully and try to create, from my vantage point, coordination among the agencies so that they can, you know, kind of achieve the best balance between what they're required to do and should be doing under law, and then the kind of removing the, as I say, the incrustations, the barnacles that develop on a regulatory system over time kind of inevitably.
And speed means next year? Or
Yeah, I mean, next year, later this year.
Later this year?
We're working pretty hard. I mean, when I came in and sort of brought the staff, the HHS staff together on this issue internally, I found a tremendous outpouring of support for this, that there were a lot of people who had been frustrated by this internally and were really looking for an opportunity, a platform to do this work. So that means there was an awful lot that had already been thought through within the agencies in many cases on these very same issues. And so they just really needed kind of a platform, a springboard to kind of move this forward. So I think that's where, I mean, that was, I mean, tremendously heartening, because, you know, it's good to see that a lot of the people internally who are experts in this area had seen the same issues that I had seen from outside with this, and so they're really sprung into action. So, I mean, we're making sure that we kind of reach out to the public to get their perspectives on this as well, because we're not trying to sort of develop a government device solution to a government device problem, right? So we're trying to make sure we get as much in reach from the public broadly, and then move forward after we've got that.
I know we were going to have some questions in the audience. In the minutes that we have, is there anybody here who would like to talk to the deputy with questions? We have a gentleman right here. Hold on, wait for the microphone.
Thank you. Bill Finnerfrock with Capel Associates. Recently, the Secretary rejected about 12 or 13 alternative payment models that were submitted by various physician organizations, and that's had a chilling effect on the efforts for innovation and things that other specialties were considering. Do you have any advice, or is there anything to suggest that the department will seriously consider alternative payment models that are going to be developed by groups outside of CMS or HHS as we move forward?
Yeah. So, I mean, if you're talking there about sort of the PTAC situation, yeah. I mean, I think that we are still ongoing in discussions with PTAC and other groups about developing alternative payment models. So we're not kind of shelving at all the idea that, and in fact, I think we're welcoming the development of models that we can put in place to implement that are going to be useful going forward. I mean, we know that that's even sort of one of the pillars that we're following, that we want to develop innovative payment models in CMS, whether inside or outside. So I think we're we've definitely reached out to the physician community, among others, to help kind of bring models in. And I know that we're going to be looking at not just the exact models that they have, which we're continuing to do as they're developed, but also kind of taking the ideas and and using the ideas that we're hearing from them internally to kind of inform also models that are being looked at inside the department. So yeah, we're not in any way kind of shutting that process down.
Who else do we have? Oh, we have another hand down here. This gentleman right here.
Good morning. Thank you for being here. My name is Han Pak. I'm the Chief Medical Officer for 3M Health Information System. I'm a practicing physician, and so I hear a lot from my colleagues about the burden of reporting and all the issues. And yeah, we want to do the right thing. And so philosophically, I guess I had a question for you regarding these process measures versus outcome measures, especially as we think about coordinating the care. We all recognize individually as a physician, we can't be the one stop that we take care of all the needs of our patients, and it takes a community. Could you talk a little bit about your approach or your department's approach regarding process versus outcomes, especially as it regards to measuring performance?
Sure.
This is a small topic.
Sure, yeah. So we've got the rest of the day and tomorrow
Yeah,
set aside
exactly.
for everyone.
PhD
So, yeah, everybody. So obviously the drive to value-based care, focusing on outcomes is got to be central to that, because we want to move to a system where we're sort of oriented on that as opposed to process-based. I mean, the movement from, broadly speaking, fee-for-service to value-based care is a movement from kind of being oriented around looking at one particular service by service, process by process, and moving to one that's oriented more on overall outcomes. Now, how you measure those outcomes is obviously a matter of great moment, right? That sort of sets the ground for how we're moving on value-based care. So, we have to look at a lot of things in there, including sort of price and quality transparency, because you have to be able to understand what's going on in the system, both from the point of view of where you're getting the prices and the costs in the system, as well as the quality side on outcomes, so that we understand not just that we're paying for quality care, but what we're getting. Like, in other words, what are we actually paying for in that system, which is something that is actually, those of you who work, it's a very complex question, is because we're moving from, and this has been true across administrations. In other words, like, value-based care is a term that's been around for decades, honestly. I mean, 20 plus years from just from my own experience. So in many ways, that's a term that could mean anything to anyone. But I think if you look at how we're building out the parts of it underneath, then you'll see kind of where we're going in terms of putting more meat on the bones of that phrase. So that, and outcomes are definitely part of that, and a crucial part of it. But it's, I think, to go even beyond the notion that we're looking at outcomes, but to see how we're going to be measuring them, how we're going to be looking at them, and kind of unfocusing on some of the process issues. And that line, you have to look at whether we've got redundant measures for reporting, where I think a lot of that has happened over time. So we're looking at kind of trying to deburden most broadly where we've got measures of performance that either are, again, duplicative, that have kind of topped out, where we've got quality measures that are sort of broadly, we're sort of paying for something that has 100% compliance, so that we're essentially doing a check-the-box exercise, which we really don't need to be doing. It wastes everybody's time on it. So we're looking at a lot of those to kind of move away from the large number of measures that have been in place over time to measure outcomes quality-wise, and figure out from a price transparency point of view what we're paying for and how we're going to determine that.
Well, thank you. I think that we promised to let you go. Thank you very much for the terrific questions. And Deputy Secretary Hardin, it's been terrific. Thank you for joining us.
Appreciate it. Thank you.
And we're going to move on.
Okay.
Thank you, Deputy Secretary Hardin and Alexis. And now it's time for the sponsor perspective portion of our program. And for that, I'd like to invite to the podium Richard Averill, Principal at the Hesperian Group, LLC, and Mark Cullen, President and General Manager of 3M Health Information Systems. Mark, the stage is yours.
Okay, good morning. So, Rich, our customers are primarily hospitals, primarily US-based hospitals. And they're under a lot of pressure from a lot of different angles: cost, patient experience, quality. At the same time, there's a lot of data out there. There's EHRs now. There's probably more data than there's ever been. Can you talk a little bit about maybe what the role of data is in helping them solve some of those pressures?
Sure. Well, as you say, there's massive amounts of data. Technology today lets us accumulate and store massive amounts of data. You have the EHRs that now can collect coded data, structured data, free text data, images, all being collected. And as we heard about earlier, we also have massive amount of vertical and horizontal integration. So now we're dealing with multiple sites of service. So data is coming in from physicians' offices, from home health agencies, from skilled nursing facilities, from same-day surgery units, from ERs, from inpatient. All this data is streaming in. And it's almost become too much data in some sense of how to go through it and sort through it all. Unfortunately, the approach has tended to be, well, we'll produce massive numbers of pre-specified reports, just piles and piles of reports. Or at the other end of the extreme, essentially what you get is we'll give you total flexibility to do any kind of drill down that you want. And so with all the data and all the flexibility, it almost becomes paralyzing for clients to try and figure out what to do, to even hire the right people who can do that and take care of and actually be able to do all the drill downs. And then on the other extreme, there's this notion of big data, that the big data technology is suddenly going to appear. It's going to be able to sort through all the data and magically give us the answers we need to manage better. So what we must figure out to do, be able to do, is to understand delivery systems and how delivery systems interact and function as an organization, to identify the opportunities for real improvement and try to get at the underlying root causes.
Can you talk a little bit about sort of the role of technology and maybe the interaction between technology and maybe the human element, the real insight that can come from that when you can put those two factors together?
Well, a lot of it is ultimately going to come down to, as I said, with vertical and horizontal integration, we're basically building many entire delivery systems. And we have to solve what I call the codependence problem. And there are various different kinds of codependencies out there. One is site of service codependency. So let's say we're looking at a hospital and they appear to have a readmission problem. Well, but if you look deeper, you find that, well, it's not so much the hospital, but they're using 2 skilled nursing facilities, and the 2 skilled nursing facilities have a readmission problem. So instead of focusing on what's going on in the hospital, you need to focus on what's going on in the skilled nursing facilities. Or conversely, do the skilled nursing facilities have a problem as they appear to do, or is it because the hospital is sending them patients discharged too quick, too sick? One has to begin to understand the interaction within the delivery system of the various sites of service and how they interact and how they influence performance across sites of service. The second is what I'll call measure codependencies. So clearly, if you're trying to understand how a delivery system is working, you want to look at as many different measures of performance as possible. So you may be looking at a hospital and you say, well, apparently they have a length of stay problem. They're just keeping their patients too long. But if you delve a little further, you find that they have a problem with complications. They have too many complications. The reason their length of stay is long is their complication rate is high. Too many patients are getting pneumonia after they get admitted. Too many patients are going septic after they get admitted. And so you don't focus on solving the length of stay problem. What you do is focus on solving the complication problem. So ultimately, what it's all about is getting at root causes. Where are the opportunities within the delivery system to improve? What are the root causes that are causing these negative performance results within the delivery system?
Okay, so Rich, I mentioned that our customers are primarily US-based hospitals. Mm-hmm. We have some business with payers. Can you talk a little bit about maybe the motivations and the role of payers and providers in getting value from the kind of insight that you're talking about?
For both payers and providers, if one is going to have a system from the payer perspective of monitoring what's going on in individual providers, from the provider perspective in understanding what is happening with their performance within their delivery network, there's basically 4 things that need to be done. First, one has to answer the compared to what question. So if you're going to improve performance, if you're going to find root causes, you have to say, well, compared to what? What that means is you have to be able to do risk-adjusted comparisons to best practice across a wide range of measures. So you need to be looking at measurement of performance, dozens of various measures, you know, the obvious things, readmissions, complications, length of stay, and so on. But there's dozens of other things to look at, and you need to be able, on a risk-adjusted basis, to compare that to best practices. Secondly, you have to identify, well, what are the root causes? How do I improve? What are my opportunities to improve? And that gets at getting at all the codependency issues that we understand. That is the thorniest problem, understanding those codependencies to be able to ultimately get at what is really the root cause of the performance problem. Thirdly, you have to be able to prioritize and focus. And so you need to be able to look across the entire delivery system and say, if I have limited resources to pursue opportunities to improvement, where do I deploy those resources? Is my major problem in the ER? How many patients are going to the ER? How much it costs for the patients in the ER? Is my major problem with the home health agencies that I'm using or the skilled nursing facilities I'm sending my patients to? I have to be able to sort all those things to get at the root causes of poor performance within the delivery system. And then finally, and I can't emphasize this enough, at the end of the day, if a delivery system is going to change, that means behavior is going to change. And more often than not, yes, sometimes it's administrative behavior that needs to change, but more often than not, it's clinical behavior that needs to change. That means that the data that's presented, how it's presented, has to be clinically credible. It has to be understandable to healthcare providers, and in particular the physician community. So it takes a lot of effort. I mean, you can't run regressions and give people a score and say your score is this and really think that that's going to really give enough understanding to motivate change. You have to do things like we did with the DRGs, where you essentially created a language. The DRGs were basically a language that said, this is how you communicate financial information to physicians. And so you have to design the entire system to be clinically credible. And so, unfortunately, I'm unaware of any system out there that actually does all that, that actually puts all those pieces together. That's why I want to mention that Verily, who's the life sciences portion of Google, and 3M have now teamed together. We basically said, we haven't seen anyone solve this problem. Let's take 3M's extensive regulatory knowledge, it's from its DRG heritage and everything we learned and try on how to improve performance, and obviously Verily's huge computing power and so on, to let's team together and see if we could solve that problem. And so we're in the early stages of releasing that, and we're going to be very excited to see how well it helps improve the delivery system.
That sounds good. Thanks a lot, Rich. We have about 1 minute left. Do we have any questions?
Hi, my name is Eitan. I work at ASPE. I was wondering if you could go into more details on the joint project between 3M and Verily.
Well, it's basically what we've done. We work with a lot of Medicaids. Obviously, we work with the federal government. We work with MedPAC. And what we've done as 3M is go out there, just like we did in implementing the DRGs way back when, we go out there and we implement systems with the objective of changing behavior, improving performance. And so we have a wide body of knowledge. In terms of how to do that. And so we've evolved that into 30 or so measures of performance of a delivery system. But we realized that to actually do that, it takes a staggering amount of computing power, a staggering amount of search capabilities. And so we asked ourselves, well, who do we know out there in the industry that could actually give us the computing infrastructure, the computing horsepower to do what we want to do? We essentially created a combinatorial problem. If we're going to look at it across all these sites of service, across all these measures, for all the subpopulations, et cetera, we will be looking at literally quadrillion of different possibilities, pockets of performance. And so that was a computing problem that was a little beyond our scope. And so we turned to Verily to partner with them to help us solve the technical aspects of the problem. Our timer says 0, so.
Okay.
Thank you so much. That was fascinating. So now we'd like to turn to our panel of experts, and thank you so much for your comments, Richard and Mark. So to provide more context and perspective on the pace of changes taking place in the healthcare market, we'd like to turn to other experts in the field. What are the companies involved in M&A activity offering consumers? Will the market support disruption, and how are issues related to access and quality of care going to be tackled? To get answers to these questions, please join me in welcoming Emily G., healthcare economist at the Center for American Progress, Nancy Roman, president and CEO of the Partnership for a Healthier America, and Corey Capps, partner at Bates White Economic Consulting. My colleague Peter Sullivan, healthcare reporter at The Hill, will lead this discussion. Peter, over to you.
Thanks. Thanks everyone for joining. Yeah, so now we've heard from our members of Congress, so we're just going to dive in a little deeper with our expert panel here. So I thought maybe I'd start with Emily and just talk about kind of what makes kind of healthcare markets different. I mean, you can go into a store and you see a price on, you know, your groceries. It's kind of easier to have a market there. Maybe, you know, we all know when we go to the doctor, that's not necessarily how it all works. So what is kind of the challenge there in trying to have a healthcare market, and how does that play into what we're seeing with mergers and acquisitions?
Sure, so I think one big difference between healthcare and ordinary consumer goods is that most of us generally aren't going out and shopping for an MRI or shopping for a emergency room visit. What we're doing is we're buying health insurance, and in many cases it's our employer who does that initial round of shopping for us. At a relatively medium to large size firm, you might get a choice of 2 different kinds of health plans, and that's it. And so when we think about mergers and consolidation, consolidating insurers, consolidating providers, well, that does increase the bargaining power, and often those entities would argue it increases their ability to coordinate care. That value doesn't always get passed down the chain, and a lot of times the cost savings is captured by those entities and not passed down to consumers. So I think we need to think about, can consumers actually shop in this market? And what's the value that consumers are getting, both in terms of lower prices and better quality care?
Right, and going down to Corey, I guess, we've started seeing has been a very active space for mergers. I mean, we've seen some of the health insurer mergers got blocked last year. What is that kind of, what lessons have we kind of learned from that, and what does that tell you about where things are going now? Does it mean we're going to be seeing vertical mergers instead of horizontal mergers, or what does that kind of tell you?
Sure, I think we all learned relatively early on that if a stove is hot, you don't touch it or don't touch it again. So the DOJ blocked 2 insurer mergers that combined firms that sell the same products in the same geographies. So that was Aetna Humana and Anthem Cigna. Less renowned, but still going on steadily. The FTC has been blocking horizontal mergers of hospitals and in some cases physician groups. So again, when they're direct competitors and there aren't a lot of other competitors, the antitrust agencies are likely to block those. So if the horizontal door is closed or that stove is hot, then you look to other doors and avenues. So rather than scale, you're starting to see more scope type of plays. And so now we see a wave of more vertical integration. And the ones that are getting all the attention, certainly the Amazon JP Morgan venture, which is a form of backward integration, potentially at least. We're not sure what they're going to do, and I don't think they are either. You're also seeing the PBM insurer deals. And alongside that, you're also seeing insurers buying up physician groups, which is sort of alongside or maybe replacing or taking the baton from a series of hospitals buying up physician groups. So now we have two competing buyers as physician groups look to scale up. We also have the AT&T ruling that came out 10 days ago or so, which sort of shows that the antitrust stove is less hot when it comes to vertical deals, although that's only one, not a trend yet.
Right. And so finally, Nancy, I mean, what is this, if you're a patient, what does this kind of mean? You know, to some extent, does it matter to you, you know, who is owning the practice or hospital that you're going to? Does it matter in terms of the price that you're paying, or what kind of things should we look for in terms of how this is actually affecting people?
Well, I don't think anyone can purport to know how everything will play out or what the unintended consequences could be. But one of the reasons I'm excited to see all this activity and potential merging is because it's disruption, and I think the system badly needs to be disrupted. And that allows for opportunity, I think, in one of the most overlooked areas, and that is preventative care, and really using some lower cost, more common sense things to prevent diseases before they happen. I mean, just to use a few statistics, you know, 38% of the public lives with obesity right now. Okay, 100 million people in the United States of America have pre-diabetes currently. You know, by 2030, it's expected that 50% of the nation will have obesity. Well, you know, there are 60 diseases and conditions associated with obesity, and we spend 20% of our healthcare dollars annually on these kinds of things. So one of the problems with the current system is it has trouble dealing with prevention. And so one of the things I like, and you know, I could talk about this for a while, but one of the opportunities I see in mergers, when I ran the Capital Area Food Bank, we tried to do a lot of work providing vegetables in hospital settings for patients that didn't have access to good food. But you know, it was very, very, very difficult for medical providers to get into the perishable food space. But you know, you have a company like CVS, they already have a supply chain that deals in perishables. And so you can imagine a world where the minute clinics would be advising people to take walks and eat well, and the things that they would need to be eating could be carried on site. And you know, you don't know exactly how these things would unfold, but clearly there's opportunity there.
Right. So now I'll just throw it open to whoever. Well, Corey mentioned the JP Morgan, Amazon, Berkshire, whatever we're calling that. You know, what do you guys, that seems to be a kind of something people are a lot of wondering about. I mean, what do any of you guys make of that? I mean, do you think that there's a lot of potential there? Is there kind of too much hype for what it actually is going to be? Or what are kind of thoughts on that?
So I agree with Corey that I think we have no idea what they're doing. But I think, you know, two interesting things about it. One, that it is a venture that's an example of how you can collaborate without actually merging. I think the second thing is it's getting a lot of hype. There are about 1 million people nationwide who work for one of those three companies, Amazon, JP Morgan, or Berkshire Hathaway. But we have a lot of opportunities already on hand for innovation. So for example, the Center for Medicare and Medicaid Innovation, Medicare has about 60 million. That's, you know, more than 60 times the size of the, you know, three-company tie-up. And we have this opportunity to innovate through CMMI, to test whether models are actually working, and to give providers an opportunity to try out different ways of lowering costs and increasing quality.
We often hear Institute of Medicine quoted for saying 30% of medical spending is wasteful. If they're only half right, there's a tremendous opportunity both internally for the triumvirate to lower their own costs and make themselves more competitive, or the shareholders better off. So there's definitely potential there. Of course, there are two dueling aphorisms. One is Trump, of course, saying that who knew this was complicated. At least Atul Gawande knows it's complicated. He does not yet run a business, but he will be, or is now. The other one, I remember in the 60s, Andy Grove, who was one of the three founders of Intel, was asked what they're going to do. He said, I don't know, we're going to try to do something that no one else is doing. And that worked out pretty well. So we'll see which applies.
Right. So Nancy, you think kind of this, you mentioned CVS. I mean, do you think kind of having more retail some people have talked about maybe Walmart is going to do something. You think kind of putting more healthcare into retail, I guess, through mergers could be a helpful thing to happen?
You know, again, as a disclosure, M&A is not my expertise, but healthier living, I have worked for the last 20 years at the United Nations, at the Food Bank, and currently at Michelle Obama's Partnership for a Healthier America, really trying to work on health and integrating it. And I think one of our problems is we're so siloed. You know, you have the hospitals, then you have the doctors, then you have pharmacies and, you know, pharmaceutical industry, and you don't have a coming together. I do see that having the retail space involved sets up opportunities to integrate it into our life. And you know, these issues that we talk about in the abstract, the high cost of drugs and every other thing, as a culture, I know this can sound a little loose, but it's really what we have to contend with. As a culture, I'm just facing this, you know, my dad now has gone on blood pressure medication. And I wish that when he picked it up or, you know, went to the Minute Clinic that they were saying to him, you know, before we up your dose, start taking a 30-minute walk after dinner. You know, I wish those conversations were embedded. So what I see is an opportunity where you have healthcare on site, access to have perishable food on site, counseling for nutrition and health on site, because until we start embedding some basic preventative measures into our daily actions, where people go and shop and live, we're going to be spending all the money on end-of-life sick care, and we all know those statistics, and that isn't really working out very well for this economy or for people's health.
You mentioned the cost of drugs, so maybe Emily or Corey, I mean, we've seen some of the pharmacy benefit managers could be involved in these mergers with Express Scripts or others. I mean, do we think that that can help tackle drug pricing if you know, Insure and PBM become, you know, merge and become the same thing, or is that just kind of rearranging deck chairs, or do you think that will make a difference?
Well, you have to look at what drives profit for a firm. So right now, there are certain costs in the healthcare system, for example, costs related to an inpatient episode of care that the PBM doesn't care about. So there's at least a potential for better coordination between drug regimens and adherence, and caring about total cost for the population, which is what the insurer who has to pay for it at the end of the day cares about. So there's a potential to align incentives through vertical mergers that combine insurers and PBMs there. It's possible that better contracts could achieve that same outcome.
I think there's a question of whether we actually need these companies to merge formally in order to get the kind of care coordination. And so I think there are a lot of things that policymakers could do to help align those incentives. And I think you know, we also need to make sure that even if, you know, there's greater synergies between, say, PBMs and pharmacies, that those savings are passed down to consumers in the form of lower premiums or lower out-of-pocket costs.
Right. I guess another question for any of you, just when talking about healthcare markets, is what are consumers or patients kind of informed enough to be able to, you know, most people, I guess, going to the doctor, you know, are mostly just worried about their illness. They're not looking at the price or anything like that. You know, is it possible, I guess, for people to be informed enough, or do people not need to be super informed for kind of the market to change and become more competitive?
I'll just say, I'm skeptical about, you know, the ability of people to shop. You know, I know Senator Cassidy is a big proponent of HSAs. I don't think we should pretend that, you know, greater price transparency or HSAs are a silver bullet. What we know from studies is that when consumers are faced with greater cost sharing, they cut down on both low value and high value services, and that's certainly something that we don't want to do. You know, most of us have insurance, I hope, and, you know, I think that we've all found that to be a very daunting task to shop for insurance, and I can't imagine having to also, you know, be in the position of shopping for my anesthesiologist and, you know, for a hospital and for, you know, specialty care. So I think there's a limited tool. I think competition only works when you can actually shop, and only about 40% of healthcare services are actually shoppable.
Well, I do agree with you about, you know, you don't want the poor consumer to have to sit around figuring out complicated medical information. But on the other hand, you know, again, I think some of these things, a piece can be the answer. For example, you know, when I was crazy enough to be trampolining with my daughter about 10 years ago and trying to do the same triple split she did, I tore my ACL very badly, and I had to have it replaced. And they gave me a choice. They said, you know, look, you can have it replaced with a cadaver's ligament or with your own hamstring. Well, anyway, that was a choice I made. Well, I chose the cadaver's ligament, but I only learned later. The hamstring was $9,000. The cadaver's ligament was $37,000. And my insurance paid for everything, so I was never confronted with any information. So I think sometimes just bringing a little light, you know, you're so detached from the cost of everything that I do think some transparency could help while not holding the end-line patient accountable for every last bit.
Right. So there could be a balance there. Yeah, go ahead.
I want to, so I don't think transparency can never be bad, and 9,000 and 37,000 may be important, and it may be that the 37,000 could have been 30,000 at some other provider, so that type of transparency can help. But I want to add to Emily's point that you can only get so far with putting skin in the game for patients because the distribution of healthcare spending is highly skewed, so 5% of the population accounts for half or more of medical spending. All of that is outside the deductible, out-of-pocket maximums, and so forth. It's not affected by financial incentives at the patient level, so it may tweak the curve, it won't bend it.
But can I just say one thing? And informing patients, you know, it's not always informing them about the complicated choices they have among and between drugs, but informing them that if they take a walk every day for a half an hour, their blood pressure will drop. Informing them, you know, about some just common sense things that can reduce their health care costs and increase their health care. That, I think, can go a long way. It doesn't require expertise. Minute clinics could do it. That should be much more thoroughly embedded in our lifestyle.
I think we're going to open up to some audience questions now. So if you have a question, you want to raise your hand, and then a mic will come to you. Right here up front. Why don't you wait for the mic to come?
Hi, Miranda Jan from Blue Cross Blue Shield Association. Do you think that mergers in the healthcare sector will ultimately help us to address the social determinants of health?
Well, that's been a bit of what I've been trying to, you know, address. You know, throughout, one of the things I was thinking about with the Berkshire Hathaway, J.P. Morgan collaborative, which I think is positive just because, again, it's disruption. But given who the employees are of those companies, it's not likely to confront the issues of those most in need and the low income, you know, part of the spectrum. And I agree very much with Emily. Look at the size of Medicaid and Medicare treating the lower and middle classes. You know, there's a lot of opportunity there. So no, I don't think mergers, you know, will solely address that, but the retail aspect does allow us to touch people where they are, and you know, it's a conversation we have to have because the rates of diabetes, obesity, all those things, as you know, are much higher among lower income populations.
I don't see a direct connection between private sector mergers and social determinants. It does seem like a ripe area for policy measures, but it's, you know, there's things we can count on the private sector to accomplish and things we probably shouldn't.
Right.
I also think in the context of employer insurance, it takes a while for, you know, something like a walk a day to materialize into cost savings. And so, well, you know, what's one of the problems is that, you know, even if my employer today convinces me to take, or my insurer convinces me to take 30-minute walk every day, in the long run, that might be, you know, save me from having diabetes or other conditions when I'm older, but, you know, it won't be I won't necessarily be with that insurer, that employer, a decade or 2 decades from now.
But even in the meeting, that can have an impact right away, just on blood pressure. So, you know, part of it is an education, but it is true about the long term.
Any other questions? Yeah.
Hi, I already asked a question, but so my name is Shim Shah, I'm a medical student, and my question is, could you discuss, this is open to all of you, could you discuss how patients' moral hazard might be impacted by private sector mergers and acquisitions?
Well, so moral hazard is basically the idea that if you're not paying for something, you're going to consume too much of it. Right now, I think Emily alluded to the fact that consumers don't make good choices. They systematically will consume more health care if you make it more expensive, and that will include both low value and high value things. And if you make it more expensive, they'll consume less, and they'll do that kind of bluntly. So you either need to incent physicians to help the patients make better decisions because they're not making it on a cost-benefit basis because they may know the cost to them, but they don't know the benefits to them. Or possibly transparency tools to better educate consumers. And so any sort of merger that drives more primary care incentives and better medical decision-making on a cost-benefit would potentially affect that. But again, it may be an indirect, not a direct connection that I see.
Any other quick questions? No? Well, I think that does it then. Thanks to our panel, and thanks all for coming.
Thank you.
Thank you so much, Peter, and our panelists. That brings us to the end of today's program. On behalf of The Hill and our sponsor, 3M, I'd like to thank all of you for attending. If you missed any portion of the morning's program, the full event video will be available on thehill.com shortly. As a reminder, please be sure to fill out your feedback surveys on your chairs, and you can hand those to any member of our team on your way out. And finally, we hope to see many of you tomorrow at the museum for our second annual Latina Leaders Summit. You can find details and register on thehill.com/events. Thank you so much, and have a great day.